Yeah, thank you for kind introduction. I'm Toki Kim from Severance Hospital, Korea. My presentation is about the validation of SARTAM score in Asian patients with ACRF. Nothing to disclose. Acute on chronic liver failure has very hazardous effect on end-stage liver disease patient's survival. This figure represent the pathogenesis of the ACLF. When the patient has chronic liver disease or compensated cirrhosis or decompensated cirrhosis, several precipitants such as viruses, drugs, alcohol, ischemic surgery, sepsis, could facilitate the decrease of liver function and eventually result in not only hepatic failure but extrahepatic failure. There are several definitions of ACRF. Among them, the CLIF-C ACRF definition is most recent and most useful and simple classification. There are the six components of organ failure: liver, kidney, brain, coagulation, circulation, respiratory failure. From this, the more than score 2 of kidney and scores 3 of another 5 organ were defined as organ failure, and the grade of ACRF ranged from 0 to 3 according to how many organ failure the patient has. There are many studies that compared the mortality predictability between ACRF score and MELD score. From this study, the CLIF-C ACRF score has highest predictability compared to the MELD and MELD sodium score for 90 days waiting mortality in ACRF patients. For the post-transplant patient survivor, ACRF grade also provide very good predictability for post-transplant mortality, while the MELD score did not show that good predictability for mortality. The ACRF has very high morbidity and mortality even before and after liver transplantation. The decision to proceed, whether proceed liver transplantation or not, is very important issues. This study is from well-designed European multi-center study. Before transplantation, the patient survivor was well stratified by the grade of ACRF. However, after transplantation, even though there are some differences between the ACRF grade, but the outcome was very excellent, and then there was no statistically significant difference between the ACRF grade. However, among the nation and centers, there were the access to liver transplantation is not equal, especially in patients with severe ACRF patients. So the author of this study insisted that we need to develop the more accurate predictive model for post-transplant outcome prediction. So a group developed the Sundaram ACRF LD mortality score, named after Dr. Sundaram, using 15 liver transplant center data from US. The 5 components were included for calculating the SALT-M score. That is age, recipient age over 50, diabetes mellitus, BMI, and circulatory failure and recipient failure. And this is the formula for the calculation. SALT-M score represents the predictability 1-year mortality after liver transplantation, and the population was all DDLD patients. The predictive power of SALT-M score markedly outperform other previous mortality model. And in a validation cohort, the SALT-M score, the predictive mortality and actual mortality was well calibrated. So the author well calibrated. So the centers can determine their policy, what is the futility of the DDLT in ACLF patients depends on the SARTEM score. So our aim of study is to validate SARTEM score in Asian LT patients with severe ACLF because Asian patient has a relatively lower BMI than Western patient, and there is LDLT predominancy, and we need extremely high pre-transplant MELD score up to near 40 for DDLT allocation. So this allocation. So we used 224 patient data with severe ACLF who has more than grade 2 ACLF, received LT in Severance Hospital, Korea. From baseline characteristics, patients who died within 1 year showed higher recipient age and higher proportion of ACCC, and the rate of DDLT or LDLT was similar, and died person showed higher rate of ACLF grade 3, and they showed higher respiratory failure. As you see, the BMI was only 23 to 24 in both of the group compared to that of the original SARTEM study. The value was about 30. So this is the difference between Asian and Western cohort. So the blue line represents the predictability of SARTEM score, which showed the highest predictive power compared to previous MELD or delta MELD, donor MELD, or BL score. When we stratify the patient into 3 groups according to the total of SARTEM score, the 1-year mortality was well stratified. In the subgroup analysis, the SARTEM score performed well regardless of LT type or duration of ICU stay and ACLF grade 2 or 3. However, in HCC patients, the predictive power was significantly lower than those without HCC. This is the distribution of SALT-M and by MELD score. As you see, we set the cutoff of high value of MELD score at 30, which was generally accepted as a high MELD score. And the cutoff for high SARTEM score was 20, because as you see, most patients with ACLF grade 2 has less than 20 of SARTEM score. So with these 2 cutoffs, we divided patients into 4 groups: high SARTEM, high MELD, high SARTEM, low MELD, low SARTEM, high MELD, low SARTEM, low MELD. So upper 2 line is the low SARTEM group, and lower 2 line is high SARTEM group. As you see, the high SARTEM has lower LT survival regardless of high and low MELD group. When we divided the ACLF grade 3 patients in 2 groups with low and high MELD group, high SARTEM group, the ACLF 3 and low SARTEM group showed lower patient survival than ACLF grade 2 patient. However, about 20% point higher 1-year survivor than ACLF 3 with a high SARTEM group. So our conclusion is, in Asian LT cohorts with severe ACLF who has lower BMI and higher LDLT rate compared to the Western cohort, SARTEM outperformed the previous MELD system for predicting post-mortality. So transplantability for patients with severe ACLF could be determined based on this SARTEM score. Thanks for your attention.